Rheumatologic testing for the non-rheumatologist with Dr. Charles Moore. Dr. Moore is a rheumatologist with Norton Rheumatology Specialist. He received his degree from the University of Louisville College of Medicine, and Dr. Moore completed his internal medicine and pediatrics residency at the University of Louisville and a rheumatology fellowship at Vanderbilt University. He's board certified in internal medicine, pediatrics, and rheumatology. He enjoys exercising, swimming, playing the piano, and spending time with family. So Dr. Moore, thank you for joining us and teach us a little bit about rheumatology.
All right, good morning. I hope you can hear me.
We can.
I'm Charles Moore. I'm one of the 5 rheumatologists here with Norton Rheumatology Specialists. And I have the pre-lunch slot, so I will try to move with some alacrity so that we may have some time at the end for questions. Our topic today is rheumatologic testing. Rheumatology is sort of unique because our testing is, in general, it's fairly difficult and it's kind of a hodgepodge. And we rely on several different modalities to diagnose our diseases, some of which are more helpful than others. What we're going to talk about today is largely the serologic testing, anti-nuclear antibody, rheumatoid factor, CCP. We are going to try to touch on acute phase reactants. Everything below that we don't have time for, but we use these much less frequently anyway. These are sort of supplemental testing. Imaging is particularly helpful in things like rheumatoid arthritis. Occasionally we get lucky and we get a biopsy, which helps us out, or sometimes we have a swollen joint that we can get some fluid out of and get some information out of. But for our purposes today, we're mainly going to be talking about serologic testing of our diseases. And so we're going to talk about some of the characteristics of these tests. The big push is going to be toward discussing indications for these tests, but just as importantly, the flip side is when not to order these tests, interpretation of the tests, and then we'll discuss briefly some pitfalls and some pearls in using these. So one slide of stats, I'm sorry, and this is just review, but sensitivity of a test, but this becomes important for our testing, as we'll see later. You probably recall sensitivity of a test is the proportion of correctly identified patients with disease. Specificity is the proportion of correctly identified without disease. Sensitivity is kind of like, I think about this usually as kind of like a fisherman on a boat, and he's trying to catch, say, tuna. And a test with a high sensitivity would be like a very big fishing net. And the fisherman throws out his net and he basically scoops out everything under his boat. And it's high sensitivity because he's going to pick out all the tuna. He's going to pretty much get all the tuna in that area. But it's got poor specificity because he's also going to pick out a lot of non-tuna. He's going to pick up, I don't know, what's out there, mackerel or halibut or something. Whereas a test with high specificity is more like a fisherman who's sort of standing there on his boat and he's spearing fish as they go by. And every time he sees a tuna go by, he spears it. And it's very specific because he's only getting tuna, because he's looking at the tuna as he's doing this, but it's not very sensitive because he's not getting very many tuna. He's missing a lot of tuna that go by that he's not spearing. And then a better test, judge of how effective a test is actually positive and negative predictive value, because these take into account the prevalence of the underlying disease. So this is basically the positive predictive value basically tells you how good is the test at picking up patients, and the negative predictive value is the opposite. So why is rheumatologic testing tough? And it's not just tough for non-rheumatologists, it's tough for us as well. We're often scratching our heads and trying to figure out what the heck is going on with patients. And a lot of it is because our diseases they overlap with everything, and our symptoms are sometimes so non-specific. I mean, there's a million reasons to have fever. There's a million reasons to have joint pain. Most of our diseases, we don't have a gold standard. Some of them we do, but the vast majority of them we don't. Our testing is pretty lousy. We have tests like an anti-nuclear antibody that have quite good sensitivity, but terrible specificity. We have other tests where the opposite is true. So most rheumatologic literature, most of our data, since we don't have gold standards, is dependent on expert opinion, which is kind of problematic. But it's important to address this because we know that inappropriate testing is a big deal for rheumatology. And we'll get more into detail on this in a minute. But we have a lot of patients sent to us for tests that probably should not have been checked in the first place, particularly anti-nuclear antibodies. And you might ask, well, why is this a problem? And in some way you could argue that it's not. I mean, I am based on productivity. These patients are easy to see. I get the RVUs. I don't have to spend very much time with them. They get to see a rheumatologist and they're happy. So in one sense, this is not a problem, but in another sense, it's a huge problem because we know that from our data that somewhere around 20 to 25% of all new patient visits to all rheumatology practices in the United States are for inappropriately tested ANAs that never should have been checked in the first place. That is a huge number of patient referrals nationwide. And again, I want to emphasize this is not a Norton issue, this is not a Louisville issue, this is nationwide. But locally, we have a huge shortage of rheumatologists. Well, we have a shortage nationwide, but it's particularly bad in Louisville. Currently, right now, if you send a patient to us, it's going to take us 5 or 6 months to get to that patient, unfortunately. And that is exacerbated by the fact that a quarter of the patients that we're seeing every day, new patients that we're seeing, we don't need to be seeing. So if we're busy seeing patients that are being sent to us that we don't need to see, that means that we're not able to see the patients that are really sick who you really need us to see, which is an issue, obviously. Patient anxiety is often an issue here. A patient will have, for instance, an anti-nuclear antibody test drawn for whatever reason. They go home and they Google it and they see where they have lupus. And these patients often have comorbidities, they have depression, they have anxiety. And sometimes they just decompensate. I see patients in clinic who has been waiting to see me for 6 months with this positive ANA. They have not been sleeping, they have lost weight, they are anxious, they are tearful, they are just miserable, thinking they have some terrible autoimmune disease. Once a week, I will have somebody essentially break down out of relief when I tell them, no, you don't have lupus, you don't have one of my diseases. There's also some sort of a somatic feedback with many of these patients, and we all have these patients. They have abdominal pain until they make you take out their gallbladder, then they still have abdominal pain. They have chest pain and they make you cath them, and then they still have chest pain. And I don't know what the best strategy is for these patients, but it's probably not continued testing to sort of feedback on their somaticism and their anxiety. There are economic factors here. We don't really think of this on an individual patient level while we're in the room with the patient, but if 25% of referrals to rheumatology practices are inappropriate, that's a lot. And then we just want to practice good medicine. We'd like to be evidence-based. We'd like to get the right test at the right time and get the right diagnosis if possible. So I mentioned ANAs in particular are the big culprit. This was a study a couple of years ago. It was done at a private practice that was associated with University of Connecticut. And what they found was 90% of patients who were referred to them for a positive ANA result had no evidence of an ANA-associated rheumatic disease. And what they also found was that a positive ANA, I mean, we already knew this, what they did was they quantified it very well, that a positive ANA checked in an asymptomatic patient or in a patient who does not really have a high suspicion of having a rheumatologic disease is a worthless test. And this is the ANA level is over here. This is a low level ANA. Obviously this goes up higher. This is a higher ANA. What they found was that we generally start at 1 to 160. If a patient was sent to them with an ANA of 1 to 160, the test was only right 3% of the time, which is not very good, which is not a very good probability. But even at very high titers, 1 to 1280, which is a very high titer ANA, the test was only right less than 6% of the time. So what this tells us is that if you have a low suspicion for lupus or autoimmune disease in these patients, even if you check the ANA and it's markedly elevated, it's still far more likely to be a false positive rather than a true positive. So we'll start with the ANA. These are the disease associations. Obviously, these are rheumatologic and non-rheumatologic. The biggies are lupus, obviously, Sjogren's. Basically, these 5 here, down to mixed connective tissue disease, these diseases should have a positive ANA. If you're diagnosing a patient with one of these and they don't have a positive ANA persistently, then you kind of have to question your diagnosis. These bottom 2, the ANA is probably more just sort of riding along. It's not really pathologic. It's probably not involved in the disease. It's just sort of there. And then obviously there are non-rheumatologic reasons to have a positive ANA. Multiple sclerosis patients have a higher prevalence. Thyroid patients, Graves' disease patients often will have a positive ANA. Cancer, infection, these are gastroenterological diseases that should have a positive ANA at some point. And patients who have idiopathic thrombocytopenic purpura will often have a positive ANA. But the most common reason to have a positive ANA is that you are a healthy adult in the United States. And most of the data suggests that if you look hard enough, up to a third of healthy adults in the United States will have a low-level positive ANA and will not have rheumatologic disease and will never get a connective tissue disease. So that's a lot of patients. This number is higher in women. It goes up with age. This was based on NHANES data in a study several years ago that estimated that at least 32 million people in the United States had a positive ANA, but did not have lupus or rheumatologic disease. So briefly, what is an ANA? Because it's kind of a complicated test itself. It's a two-part test. The first part is immunofluorescence, and basically the tech in the lab takes a slide. This slide has, this is not to scale obviously, but the slide has human epithelial cells stuck to it, and then they react the patient's serum over the slide. And if the patient has an anti-nuclear antibody, one of those antibodies are going to stick to something on the nucleus. Then they add a second antibody, a developer antibody that has a fluorescent moiety stuck to it. And then they take it into a dark room and they look at it under a fluorescent microscope. So this is a positive ANA. We know that there's some antibody in the patient's serum that's sticking to the nucleus of this cell. These are all nuclei. The cell body is kind of out here where you can't really see it very well. And then the tech will repeat this test, diluting the patient's serum each time. And that will give us sort of a quantitative estimate of how much antibody is in the patient's serum. If the antibody persists at higher dilutions, then there's more antibody. And the third piece of information is it gives us a pattern. So this is a smooth pattern ANA. The nucleus kind of lights up homogeneously. This is a centromere pattern. You'll essentially only see this pattern in patients who have scleroderma, specifically limited cutaneous scleroderma. This is nuclear pattern. This is most likely to show up in dermatomyositis or myositis. And then this is speckled pattern. This is the most common pattern. So that's the first part of the test. It tells us an antibody is present. It gives us some idea of how much antibody, and it gives us a pattern. We would like to know if we could identify that antibody, if possible, because that gives us some good information as well. And so that's the second part of the test, which is simply an ELISA. And here you have a plate or a well, and then you have a known antigen. So say you're looking for double-stranded DNA, you have double-stranded DNA stuck to this plate, and then you do the same thing you did before. You run the patient's serum over it. If they have an anti-double-stranded DNA antibody, it's going to stick. And then you have your developer system, which is either a fluorescence or an enzyme developer. And so that will tell you if the patient has a specific antibody that we can identify. And these are those associations. So lupus patients essentially can have any of these antibodies, except these. These are pretty specific for scleroderma. But the more specific antibodies for lupus would be your anti-Smith and your anti-double-stranded DNA. Sjogren's syndrome patients should have an SSA-Rho antibody. Scleroderma patients, if they're going to have one, will probably have this. Histone is classically drug-induced lupus, and an RNP antibody is required to diagnose a patient with mixed connective tissue disease. Now, lupus, you can also diagnose without one of these antibodies. You don't have to have one of these specific antibodies to say somebody has lupus. They have to have a positive ANA by immunofluorescence, but they don't necessarily have to have one of these antibodies. So when do I order an ANA? And it sounds flippant, but if you have some objective evidence of underlying connective tissue disease, that would be a reason to order an ANA. That's harder than it sounds, unfortunately. Lupus in particular sort of has the reputation of sort of a kitchen sink disease where I don't know what's going on, so I'm going to order an ANA. Patient comes in and they say, when I turn on the microwave oven, my left foot turns blue and my right arm shakes. So I'll check an ANA. And that's not actually the case. Lupus, we're using lupus here as the example. Lupus has specific diagnostic criteria. And if the patient does not have those diagnostic criteria, then there's no reason to check an ANA. This is our current sort of American College of Rheumatology scheme for lupus. We do not actually use this. This is a point system. We don't actually use this in clinic to diagnose patients. This is more intended to sort patients into studies, so that you know that if a patient is in a lupus study, that they qualify. But this gives you an idea of what we're looking for in lupus patients. And these are different domains. We have hematologic, neuropsychiatric, skin. And what's important is these are objective. You can see these either in front of you or on a blood test. So it's not that the patient, you know, feels feverish or has night sweats. This is fever. It's objective fever. It's not memory loss or fatigue. It's actual neuropsychiatric symptoms that you can see. Joint involvement. This should be objective. This is not, I hurt all over or have muscle pain. This is typically what we're looking for is synovitis, which we'll see later. So this is what we're looking for when we're considering about whether or not we need to check an ANA in a patient. And these patients they're generally sick, and they generally have objective evidence of widespread disease. So it's not, I get a little red flushing in the sun. I mean, it's a real significant rash. The malar rash, the so-called butterfly rash of lupus, generally these patients are sick and they have often renal disease. It's not, I burn in the sun and I didn't used to. I mean, these patients have significant morbidity. And back up for a second, what is not on this list? Because that is actually just as important. Fatigue is not on that list. Fatigue is not a diagnostic criteria for lupus. Do our lupus patients have fatigue? Sure. But so do cardiac patients and cancer patients and everybody else. We don't use fatigue to diagnose the disease. Some people will get an ANA during an annual physical exam in asymptomatic patients, which is kind of the opposite of what an ANA should be used for. It's not a screening test. It is a terrible screening test. I hurt all over. That's not a symptom of lupus or connective tissue disease. Family history of lupus would not be an indication to check an ANA. I can't stand the sun. My hair is thinning. I feel terrible headaches, migraines, tingling, numbness. These are all symptoms that our lupus patients may get, but it's not because they have lupus. It's usually because they have fibromyalgia. Most of these symptoms are fibromyalgia symptoms, not lupus symptoms. But none of these are diagnostic of lupus in themselves. So the situation that we usually see most often when these patients are referred to us, this is how you read an ANA. And the titer, this is the immunofluorescence portion. And so this was negative actually. So this tells us that the immunofluorescence portion was negative. The overall test was positive, and the pattern is negative because there was no pattern to see because the immunofluorescence portion was negative. The overall screen is reported as positive because they had one of these antibodies. So the lab will report this as the ANA is positive, either if the immunofluorescence is positive or if the Eliza is positive. So in this case, what we usually see is a patient will have an ANA check, the titer will be negative or trivially elevated, and then they'll have one of these antibodies at a low level. Typically the RNP seems to be the one that's most commonly comes back positive, but any of these will come back positive at times. So the key with the ANA is keep an eye on your pretest suspicion, because if you have a low pretest suspicion, like I said earlier, even a high titer ANA is worthless. And in lupus specifically, lupus is more, well, immune diseases in general, but specifically lupus, it's more common in women and in the men, much more common in African Americans and Hispanics more so than Caucasians, and more common in young people rather than older people. So particularly if you're thinking about checking an ANA in an elderly man, you should really think twice before you do that. The one caveat is drug-induced lupus, which does occur in the elderly. There are some medications that will trigger a positive ANA and a lupus-like syndrome in some people. These patients don't typically present with typical lupus symptoms. They usually present with fever and serositis. So you're not generally going to confuse this with regular lupus. There is no, I touched on this a couple slides ago, there is no indication for lupus testing or autoimmune testing in the evaluation of fibromyalgia. Patients with fibromyalgia have symptoms of fibromyalgia. Patients with lupus have symptoms of lupus. There may be some overlap, but they're different diseases with different symptoms. I'm going to skip preclinical lupus. The upshot is that your clinical judgment always trumps your labs. So even if I see a patient who has, their labs look like they have lupus, if they don't have clinical evidence of lupus, they do not have lupus. Rheumatoid factor is basically an antibody against another antibody, and they're not necessarily pathologic. They're part of the immune system's cleanup crew to clean up antibodies when they're no longer needed. They're seen in rheumatoid arthritis, obviously. They're often seen in Sjogren's syndrome, juvenile arthritis. Sometimes they're riding along in lupus. They're often present in infections, cryoglobulinemia, malignancy, and again, high background rate, similar to the ANA. Up to a third of patients, or up to a third of healthy adults in the United States will have a low-level rheumatoid factor at some point. The big infection would be hepatitis C, either current or past hepatitis C. These patients almost all have a positive rheumatoid factor. As you can see, the sensitivity is poor and the specificity is poor because there's all these other reasons to have a positive rheumatoid factor. Anti-CCP is more specific for rheumatoid arthritis. This is a more recent antibody within the last 10 years or so. It's really only seen in rheumatoid arthritis. There are some people who will have a low-level CCP who don't get rheumatoid arthritis, but it's the specificity is better. Sensitivity is pretty lousy because most patients, at least with early RA, will not have a CCP. And similar to lupus, there are criteria that we use to diagnose rheumatoid arthritis. Rheumatoid arthritis is not just joint pain. In fact, in diagnosing rheumatoid arthritis, we don't care about joint pain. What we're looking for is synovitis. This is objective. This is objective swelling that we can see and feel on our exam. And then you count up the joints and they get a score and you decide if they can be in a rheumatoid arthritis study or not. Interestingly, elevated CRP and sedimentation rate are almost worthless in diagnosing rheumatoid arthritis. So this is what we're looking for. This is squishy, swollen joints. They might be hot, they might be warm, but you can see this, you can feel this. This is not, I have sore joints for the last 10 years. This is, you know, here you've lost the valleys between the MCPs. You can see this. Patients who have severe hand osteoarthritis can also get some of this, but it's bony. When you squeeze this in an osteoarthritis patient, it's hard knots. In a rheumatoid arthritis patients, this is squishy, for lack of a better term. So that's what we're looking for. I'm going to skip the x-rays. So our pearls and pitfalls for rheumatoid factor, just keep in mind that arthralgia is not arthritis. They're different. Arthralgia is joint pain. Arthritis is objective evidence of underlying inflammatory inflammatory arthritis, and that's what we're looking for. I usually don't check rheumatoid factor in somebody with a history of hepatitis C. It's going to be positive anyway, so don't bother. This is where the anti-CCP antibody is particularly helpful. It's not thrown off by hepatitis C. And similar to the ANA, your clinical judgment trumps everything else. Acute phase reactants are sometimes helpful, and we get a lot of referrals when these are abnormal. Sedimentation rate is actually not technically an acute phase reactants. It's an indirect measure of other acute phase reactants. And what happens here is that normally red blood cells have a negative charge, and so they kind of repel each other, and they stay suspended longer in a tube. When there's inflammation, for whatever reason, you have more fibrinogen floating around, more immunoglobulins floating around. You just have more stuff floating around, and that sticks to the red blood cells and sort of cancels out their negative charge, and they're able to stick together. And things that clump together fall faster in a fluid than things that don't clump together. So if you have a lot of inflammation, the red blood cells stick together and they fall faster in a set amount of time. So that's the sedimentation rate. It's a horribly non-specific test. It can be elevated for a bazillion things. Oops. Which we see here. Yes, it can be elevated in rheumatologic disease, particularly temporal arteritis and polymyalgia rheumatica. It plays a prominent role in diagnosing those. But it's also up in pregnancy, chronic kidney disease, anemia, cancer, infection, non-rheumatologic disease like inflammatory bowel disease. It's higher in obese patients, it's higher in smokers, and it goes up with age, and it's higher in women. So in the lab, gives you a SED rate and it's got the little exclamation point on it that says that it's abnormal, it may not be. A good way to correct this is if you take in men aged and divide it by 2, women aged plus 10 divided by 2. That gives you sort of a corrected SED rate. So for example, in an 80-year-old man, a SED rate of 40 is okay. That's a normal SED rate. Even though the lab is red and you've got an exclamation point by it, it's not abnormal. In women, in an 80-year-old woman, for example, for a SED rate of 45 is okay. And that's pretty high. And then maybe the man is obese and is a smoker. Well, I probably wouldn't get too excited if his SED rate went as high as 50 or maybe even higher. So keep that in mind when you're getting results back on a SED rate. The second one we commonly use is C-reactive protein. This is manufactured in the liver in response to inflammation. And it's pretty much the same situation as the SED rate. It's horribly nonspecific. It's present or elevated in a bazillion things. It also goes up with age and gender. One advantage the CRP has over SED rate is that it goes up faster and it comes down much faster. So it's kind of a better snapshot of what is going on at the time with that patient. So like we've already said ad nauseum, these should not really be checked without clinical suspicion. They may be discrepant. I typically get both of them. They may be discrepant because the CRP may be normal because whatever happened a week ago is gone and the CRP has normalized, but the SED rate has not yet. It may be discrepant because some viruses will trigger a high SED rate, but they will inhibit the liver making CRP. So I typically will get both when the time comes. And these should be rechecked. We get a lot of referrals for abnormal SED rate or CRP, but you kind of can treat these like a fever. If a patient comes into your office with a fever, you're probably not going to worry too much about that initially. It's probably not, it could be something horrible, but it's probably not. And if you wait a week or two, it's probably going to go away. If the patient's okay otherwise, you can do that with a SED rate and a CRP too. We get a lot of referrals where someone will come in with a CRP that's elevated. It takes us 6 months to see the patient, obviously. And by the time we see the patient, the CRP has been normal for 4 months, and they're wondering why they're in our office seeing us. So if a patient has a persistently elevated SED rate or CRP, then yeah, that would be a reason to value for further evaluation. But you might want to make sure that it sticks around first, because like I say, these are very nonspecific and they fluctuate wildly, sometimes day to day. And as always, use your clinical judgment over the labs. If the labs are telling you one thing and what you're seeing in front of you is telling you another, go with what you see in front of you. So I'm going to stop there. I don't know if anybody has any questions.
So we have a few questions that came up in our Q&A section. So the first question that came in sort of points to the patient that you referred to that gets a cyanotic left hand and a numb right foot every time they turn on the microwave, and they're convinced that it's a rheumatologic emergency. So do you have any sort of strategies to discuss with them that it's highly unlikely that it has anything rheumatologically associated with it, and not to get the testing that we know is, using our judgment, is absolutely unnecessary?
I usually just tell them basically what I said earlier. I point out that yes, lupus has specific criteria that we see, and you don't have any of those criteria. Now, I understand that some of this is driven because the patient doesn't want to hear it from you. They want to hear it from the specialist. And I do understand that many of those patients that come to us, that's often what's driving that process. And they're not going to believe the primary care doc. And when the primary care doc says you don't have anything to suggest lupus, some patients are not going to be happy with that. They're going to want to hear it from me, I guess. But that's just what I point out to them. And sometimes I'll even pull up the criteria and I'll say, you don't have this, you don't have this, you don't have this. Often these patients have fibromyalgia, which is another talk maybe for next year. But fibromyalgia, other than pain, fibromyalgia patients have autonomic dysfunction. They have neurologic symptoms. They have urinary symptoms. They have gastrointestinal symptoms. So rather than lupus being sort of the kitchen sink diagnosis, a much better kitchen sink diagnosis is fibromyalgia. But again, that's another talk for another day.
Thank you. We have a couple other questions, but it looks like that we are currently out of time. Is it okay if we send these questions to you and get responses so that they can be included in our email to the group?
Yes, that would be fine.